So in these sessions we'll be dealing with the external ear and tympanic membrane. So we will deal in three different sessions. One will be the auricle, one will be the external acoustic meters, and the last one will be the tympanic membrane. So let us start with the different parts of the ear under which what we are going to study. Like if you see, the ear has three components: the external ear, middle ear, and internal ear. The external ear is having auricle and external acoustic meatus. The middle ear is having six walls, namely the roof, floor, anterior wall, posterior wall, medial wall, and lateral wall. So we will deal with the middle ear in a separate class. So time being, today we'll be discussing in addition about the lateral wall of the middle ear, that is the tympanic membrane, which forms the partition between external ear and middle ear cavity, that is the tympanic cavity. So middle ear also consists of ear ossicles, namely the malleus, incus, stapes, and there will be joints between these ossicles, and there will be two muscles, the tensor tympani and stapedius, and additionally some nerves will be there. So internal ear is mainly made up of an outer bony labyrinth which is filled with the perilymph. So this perilymph separates the bony labyrinth from the membranous labyrinth, and the membranous labyrinth is filled with the endolymph. So within the membranous labyrinth there will be organs of hearing, that is the organ of Corti, and organs of equilibrium, namely the macula and crista ampullaris. So ear is divided into external ear, middle ear, and internal ear. So today we'll be dealing with the auricle, external acoustic meatus, and the lateral wall of the middle ear, that is the tympanic membrane. So now you can observe here, this is the external ear component, this is the auricle, this is the external acoustic meatus, and here you can see this is the middle ear, where you can see this is the tympanic membrane which forms the lateral wall of the middle ear, and you can see these are the three ear ossicles, the malleus, incus, and stapes, and here you can see the inner ear. Inner ear is having the outer bony labyrinth and inner membranous labyrinth. So auricle is like a trumpet. So it is an undulating projection from the side of the head. It is trumpet-like, collects sound vibrations. So it collects the sound vibration from all directions, and through this the sound vibration enters into the external acoustic meatus, which conducts the sound vibrations to the tympanic membrane. And the tympanic membrane, through its connections with the ear ossicles, will pass these vibrations to the internal ear through the fenestra vestibuli, oval window. So now let us see here, coming back to the auricle, it is trumpet-like undulating projection from the side of the head, collects sound vibrations, and the skin is covering the auricle, and the auricle is actually made up of a single piece of yellow elastic cartilage, and this cartilage of the auricle is also continuous with the cartilaginous part of the external acoustic meatus. There is a one part in the auricle where the cartilage is absent, that is the ear lobule. So if you see the main features from the lateral surface, there will be a helix which forms the peripheral limb. The anterior limb is called as crux of helix, and the posterior limb presents the Darwin's tubercle. So you can see here, this is the anterior limb which is called as crux of helix, and this is the posterior limb which presents a Darwin's tubercle. Antihelix, it is present in front of the posterior limb of the helix. Above it divides into two crura to enclose triangular fossa. You can see here, this is the antihelix in front of the posterior limb of the helix. So above it divides into two crura to enclose the triangular fossa. Triangular fossa. So scaphoid fossa is between the helix and antihelix. You can see here, this particular one is the scaphoid fossa between the helix and antihelix. Now you can see there is concha and symboconcha. So symboconcha is the topographic location for the suprameatal triangle. The crux of the helix, when you see here, the anterior limb continuing of the crux of the helix divides this entire concha into a small area called symboconcha, which represents the topographic location of the suprameatal triangle. And here you can see this is the concha proper, which leads into the external acoustic meatus. So crux of the helix separates the symboconcha from the concha. So here you can see this is the tragus, and this is the antitragus separated by the intertragic notch, intertragic notch. This is the fibrofatty filled ear lobule. Okay, fibrofatty filled ear lobule. So main features are, this entire thing is the helix. This is the crux of the helix. This is the Darwin's tubercle. This is the antihelix. These are the two crura of the antihelix enclosing triangular fossa. This is the scaphoid fossa between the helix and the antihelix. Here you can see the Simba concha above the crux of the helix. Here you can see the concha proper below the crux of the helix. Here you can see the tragus, antitragus, and intertragic notch. So tragus, antitragus, and intertragic notch, I have shown them on the diagram, and you can see the external acoustic meatus opens into the concha. In ear lobule, it is a skin covered flap of fibrofatty tissue. So as you see, this concha is a depression on the lateral surface. So this will have eminence on the cranial surface. So that eminence is called as eminentia concha, and the triangular fossa will have eminentia triangularis. So whatever depression we see on the lateral surface will have an eminence on the cranial surface of the auricle. So this is the lateral surface what we are seeing, the other side will be the cranial surface. So when we are understanding the arterial supply, nerve supply, venous drainage, all those things, we deal in two parts, that is the lateral surface and cranial surface. So you can see here, this is the piece of the cartilage of the auricle. You can see this is containing with the cartilaginous part of the auditory tube. Cartilaginous part of the auditory tube. You can see this is the tail of the helix. So this is the fissure, antitragohelicine fissure. You can see the tragus, you can see the antitragus, you can see the intertragic notch. You can see here, this will be the helix, this will be the antihelix. You can see the triangular fossa, you can see the two crura of the antihelix. This will be the concha, this will be the Simba concha. You can see the medial surface of the auricular cartilage. So you can see the sulcus antihelicis transversus. You can see the eminentia concha. You can see the ponticulus. You can see the tail of the helix. You can see the cartilaginous part of the external acoustic meatus. You can see the spine of the helix. Spine of the helix. Remember the spine of the helix. When we deal with the auricular muscles, it is important for us. So now, muscles of the auricle, two sets, extrinsic muscles and intrinsic muscles. So extrinsic muscles, so action of these muscles are insignificant in humans. So three muscles, auricularis anterior, auricularis superior, and auricularis posterior. So origin, as we study the muscle under headings origin, insertion, nerve supply, action, we can see here auricularis anterior, origin from the epicranial aponeurosis, insertion to the spine of the helix. Nerve supply is temporal branch of the facial nerve. Movement of auricle in corresponding direction. So moves the auricle anteriorly. Auricularis superior, origin from epicranial aponeurosis, insertion to the upper part of the cranial surface of the auricle. Again, temporal branch of the facial nerve. So it elevates the auricle. Movement of the auricle in corresponding direction is elevation of the auricle, as this is the superior muscle. Then auricularis posterior, origin from mastoid part of the temporal bone, insertion into the eminentia concha, supplied by the posterior auricular branch of the facial nerve. So it moves the auricle posteriorly. So it is very difficult to appreciate these movements in humans until unless the person is practicing the movements from childhood. He might move the ears anteriorly, posteriorly, and superiorly with the help of these muscles. You can see here auricularis superior, and you can see here auricularis posterior. These two are the extrinsic muscles, whereas these two are the intrinsic muscle, obliquus auriculae and transversus auriculae. So intrinsic muscles will modify the shape of the pinna. Again, this is insignificant in humans. Very difficult to record the RA insertion in humans. So they are helicis major, helicis minor, tragicus, antitragicus, transversus auricle, and obliquus auriculae. Nerve supply. Lateral surface muscles are supplied by the temporal branch of facial nerve, and cranial surface muscles are supplied by the posterior auricular branch of the facial nerve. So you can see here helicis major, helicis minor. You can see the tragicus and antitragicus. Earlier in this diagram I have shown the transversus auriculae and obliquus auriculae. So ligaments, if you see extrinsic ligaments, anterior and posterior ligaments, which will connect auricles with the temporal bone. Intrinsic ligaments connects various parts of the cartilage of auricle. So one of the strong ligament connects tragus to the crux of the helix and completes the external acoustic meatus in front. Skin is adherent to the cartilage. Numerous sebaceous glands in concha and scaphoid fossa. Hairs will project from tragus, antitragus, and intertragic notch in elderly males. So this is the expression of violent genes. And there are significant arteriovenous anastomosis within the skin of the auricle. Then arterial supply and venous supply. So if you see the cranial surface and posterior part of the lateral surface, mainly by the posterior auricular branch of the external carotid artery. So anterior part of the lateral surface is mainly by the anterior auricular branches of the superficial temporal artery. So upper part of the cranial surface is by occipital artery. Veins accompany the arteries and drains into superficial temporal vein and external jugular vein. So lymphatic drainage, anteriorly parietal lymph nodes, posteriorly mastoid lymph nodes, and inferiorly the deep cervical lymph nodes, the upper group. So you can see here the cranial surface as well as the lateral surface. The posterior inferior part of the lateral surface and majority of the cranial surface is mainly by the great auricular nerve. And the anterior superior part of the lateral surface, you can see the auriculotemporal nerve. So in the depth of the concha, you can see the auricular branch of the vagus, and here in the upper part of the cranial surface, you can see the lesser occipital nerve. So great auricular nerve, cranial surface and posterior part of the lateral surface, lesser occipital nerve, upper part of the cranial surface, auriculotemporal nerve, anterior part of the lateral surface, auricular branch of the vagus, concha and eminentia concha. So here if you observe, if you see the left ear, you can see there is a duplication of the auricle. This is called as polyotia. You can see when it is pulled apart, you can see there is a duplicated ear here, common external acoustic meatus. This condition is called as polyotia. And here you can see in the same patient on the right side, you can see a small appendicular projection. That means this defect is observed only on one side. So now if you see the anomalies of the auricle, anotia is complete absence of the external ear and is most likely caused by a developmental disturbance between the 7th and 8th gestational weeks. So cryptotia, hidden or pocket ear, is an abnormality of the auricle where the upper pole is buried beneath the temporal skin. It can be restored to a more normal form by a sequence of surgical procedures that involve the use of splints to create a new scaphoid fossa and grafts or local flaps to release the cartilage from the side of the head. Microtia, diminutive ear, is usually an isolated congenital abnormality but is sometimes associated with recognized syndromes. Example, fetal alcohol syndrome, maternal diabetic syndrome, thalidomide and isotretinoin exposure. Then polyotia, so which I have shown in the diagram, also known as mirror ear, is caused by persistence of preauricular tissue that would normally be included in the pinna but instead lies in front of the tragus in the posterior aspect of the cheek. Polyotia. Then Stahl's bar, also known as Satyros ears, is a common congenital deformity of the auricle where the helix is flattened and the upper part of the crux of the antihelix is duplicated, producing a ridge of cartilage running from antihelix to the rim of the helix, a ridge extending from antihelix to the rim of the helix. This causes a pointing of the ear and a reversal of the normal concavity of the scaphoid fossa. This is called as Stahl's bar. So occasionally the upper part of the pinna flops over to produce an appearance known as lop ear. A variety of surgical procedures have been designed to correct this deformity using external molds. So attempts at correction are made in the neonatal period while the cartilage is soft and pliable. Delay until such time as the cartilage has become stiff may jeopardize a good outcome. So prominent ears, also known as bat ears, are caused by the absence of inadequacy of antihelical fold. So preauricular sinus is an additional anomaly. So when we see the development, there will be 6 auricular hillocks, the embryological precursors of the auricle. They form around the margins of the dorsal portion of the first branchial cleft, 3 on the caudal edge of the first pharyngeal arch and 3 on the cranial edge of the second pharyngeal arch. They fuse to form the auricle and surround the dorsal end of the first branchial cleft, from which the external acoustic meatus arises. So sinuses and cysts are often found just anterior to the root of the helix, near to the point of fusion of the hillocks derived from the first branchial arch, and those derived from the second branchial arch. So when the three hillocks from the first branchial arch and three hillocks from the second branchial arch fuse, so that particular point of fusion, there are chances of failure of fusion resulting in formation of sinuses and cysts. So there is a debate as to whether the abnormalities of epithelial inclusions between the hillocks are remnants of the first branchial cleft or not. The sinuses may be simple pits or complex branching sinuses that occasionally extend deeply towards the external acoustic meatus so that they lie close to the facial nerve. And clinically, they may become chronically infected and require surgical excision. This may be technically demanding surgery given the close proximity to the facial nerve, because any kind of injury to the facial nerve will result in facial nerve palsy, intranuclear type of facial nerve palsy. Thank you.